Welcome back to Healthcare Rounds. I'm your host, John Marchica, CEO of Darwin Research Group. Our guest today is Dr. Kamal Golla, Senior Medical Director for Value Transformation at Evolent, a specialty and primary care management company, and he leads the implementation of innovative value-based care models in specialty care. So I'm really excited to talk to you today, Dr. Golla. We've got a lot to talk about. This is a massive topic. I should tell you, we're going to do a 4-hour podcast today, just so that you know. No, we could probably, but we're going to stick to about a half hour. So just to get us started, maybe just orient us into your background a little bit and then what brought you to Evolent.
All right, perfect. Well, thanks again, John, for having me on your show, and excited to talk about this topic with you. So I always open up when I talk about how I end up at Evolent with the fact that I'm a urologist that lost his way. So not a lot of urologists in the space of, innovative care models and thinking about value-based payment models. And so my background is I'm a urologic oncologist. I actually still practice 1 day a week out of the Durham VA. And prior to coming to Evolent, I actually worked at the Center for Medicare and Medicaid Innovation, CMMI. And when I joined, we had just started thinking about specialty strategy, how to fit those into the variety of primary care focused models that were already in flight at launched by CMS. And so a lot of my work as a specialist in thinking outside of the world of urology really was how do we think about specialty care's fit into primary care? What does it look like in terms of addressing a lot of the gaps that we're seeing in specialty care and primary care integration? And was fortunate enough to play a big part in the creation and the launch of the Making Care primary model, which we'll talk a little bit about today. And then, shortly after that, opportunity came knocking, and I joined Evolent. And Evolent, as you mentioned, we really think about managing some of the most complex clinical conditions, which are oncology, cardiology, and musculoskeletal disease, as well as having a primary care arm called Evolent Primary Care. And what we really try to do is develop the right incentive models, the right clinical pathways, and in general, think about how do we manage whole person health for patients that have these complex clinical conditions to be able to drive both clinical quality, but also think about savings and improving costs of care that are delivered for these conditions. So I've coming on a little over a year there now, and excited to share some of the work that we do as we talk today.
Great. Well, I'm going to orient you a little bit on my background too. Listeners of this podcast will have undoubtedly heard this in a few other episodes here and there. But my interest in this topic started after I sold my previous company and went to go work on a PhD in Dartmouth in an interdisciplinary program. And back in sort of like 05, 06, 07, that time frame, we were doing these models, these sort of theoretical value-based care models in our PhD seminars, and evaluating how well they might work, pitfalls, things like that. And Dr. Elliot Fisher and some others from Dartmouth were, I would say, instrumental, were very important in the development of some of the models of the Affordable Care Act. So I come to this just like you. I've been in this a while, except the difference being I'm just on the research side. I'm not really implementing anything. So my first question is going to sound like the biggest windup of all, but I want you to give just sort of your assessment of, in general, so not necessarily talking about Evolent, but just in general, where we are today with these value-based care models. And I asked that question with you to think about, back around the development of ACOs and bundles and other things that were being implemented early on with the Affordable Care Act, and, kind of where we are today in 2024, which is multiple iterations of ACOs, different types of models, we'll call them, in the CMS world. Lots of different demonstrations, lots of different experiments out of CMMI projects. So we've learned a lot, but I'm going to stop talking now. Give you an opportunity to talk about your expertise and really where we are today in terms of value-based care.
Okay, yeah, happy to. And I think what's always helpful here is just, again, starting with some historical context. I think you laid some good groundwork for that. So, as we think about where healthcare transformation is focused for the past 10 to 15 years, it's really been on the creation of, as you mentioned, accountable care organizations. And, just for the audience more broadly, these are entities that are made up of a group of healthcare providers whose goal is to really improve the quality of care for their population of patients. And in addition to quality of care, they're also responsible for cost of care for that population. And these types of models, really help promote in their best use case and in their best form of implementation, help promote a longitudinal care experience for the patient that is hopefully more focused, again, I'll use this word a lot, on their whole person health needs. And then, I think one of the things that we're seeing in this transition from accountable care organizations and all of the innovation that's gone in this space is an important note in that the focus to date has really been on entities delivering on high quality primary care provider focused metrics and costs. And really to address, the full range of a patient's needs, we have to think about not only primary care, but also how specialty care. So for example, oncology, cardiology, musculoskeletal diseases, to name a few, are also addressed. And so, we are seeing a pretty rapid increase in general in the number of value-based care arrangements that across the country. So if you look at Humana data for Medicare Advantage as an example, about 70% of patients are in some sort of value-based arrangement. And again, there is a wide spectrum of what that definition could fall under. And so that's a growth of over 2.3 million members in value-based arrangements in the past decade. And then more broadly, we are seeing policy influences like the CMS mandate, which states that they want by 2030 to have nearly all Medicare beneficiaries in some form of accountable care relationship. So I think right now the current numbers, just ballparking here, is financially about 41% of healthcare payments in the U.S. are in value-based, contracts. And I'm just caveating, of course, that this doesn't necessarily mean specialty care, which is obviously one of the focuses is thinking about both specialty care and primary care, like I mentioned, but just generally in value-based care arrangements.
So, how much of that has changed over time in terms of acceptance? Like, one of the things that I've always thought is that a lot of the Affordable Care Act and a lot of things like ACOs and talking about these value-based models was really to sort of reorient people's perspective. Like, if you go back to the days of managed healthcare in the 80s and 90s, and one of the common complaints is that it was just all about denying service and cutting services, and that's the way that you controlled costs. Well, you just didn't pay for things, right? But I think certainly by the time that I went back to school, most people said, well, that was very short-sighted. It left a lot of people unhappy, did not put the patient first, and there were a lot of penny wise and pound foolish decisions maybe that were made during that time. And so this concept, that Don Berwick says he didn't invent, but he was part of the trio in talking about, the triple aim and things like that, really got people to thinking. But I remember in even the earlier days and going to ACO conferences and things like that, there was still this sense of, such a tired analogy. Everybody uses it, but it makes sense. When you're in the canoe and the lake, and it's 1 foot in the canoe and 1 foot on the shore, and trying to move forward towards these value-based payment systems, and then people saying, well, it'd be nice, but everything that we know of is paid for by doing more services. And so So I guess my question really is about how have you seen an evolution in people's thinking, which, 10 years ago, a lot of folks would say, great ideas. I don't know how this is going to happen in practice.
Yeah, I think when we think about value-based care, it would be, somewhat foolish to not think about there are just a number of headwinds, either some of the historical context around, you know, utilization management or prior authorization used inappropriately to really cut down on costs, maybe not think as much about quality, or the implementation of certain, models that was frankly very complex and hard to see where the value was in terms of measuring them. And I think there's a couple of underlying principles there. I mean, value-based care is a hard thing to implement and to, design around when currently a large amount of our healthcare system is still based in a fee-for-service world. And so I think those things for people like us who are innovating in that space, we understand that. But what we're willing to do is realize that the current way we're delivering healthcare isn't sustainable or appropriate. And so while there are headwinds, let's figure out how to solve for them. And I think, one of the, big turning points is that we've had a great foundation in some ways of changing people's perspectives as well as patients' perspectives on how to deliver better care that thinks about each part of their condition or each part of their journey. And patients, frankly, are asking for that, especially post-COVID, with all of the issues that we're seeing with regards to access to care, with widening disparities in care. We know that a fee-for-service system isn't going to solve for those. And so I think there has been a shift in how we think about value-based care. There are more and more entities, whether you call them risk-based conveners or even traditional health plans, that realize that they have to change the way that they currently practice medicine, how they think about delivering care for their patients and improving the quality of care delivered for their patients, as well as thinking about costs. And when we think about specialty care trends, I think that's probably a big trigger for why we're seeing some of these changes, to tell you the truth. Within the U.S. healthcare system, again, specialty diagnostic and treatment approaches to patient care are largely dominant. We're seeing, 30% of patients are referred to their PCPs to specialist providers. 50% of the all outpatient appointments take place with specialists. So, said another way, if you're a Medicare patient in like 2019, you saw an average of 50% more specialists in the outpatient setting than in the early 2000s, which means that a primary care physician or these risk-bearing accountable care organizations have to work with double the number of physicians in order to coordinate care and manage costs and improve quality. And so when we think about just how much fragmentation exists in that system and continued fee-for-service, we have to think about better ways to design models to manage those costs and improve quality for those patients in a way that makes sense and it's much more cohesive.
Is one of the reasons why, I haven't really thought about this issue very much, Dr. Golla, but it's one of the reasons why that we're seeing, a greater proportion of patients or these visits being specialty rather than primary care, is that a lot of the barriers have been removed. In other words, there were really tight barriers from going from primary care to specialty care in the 90s and 2000s. Have some of those been removed with the thinking that adding another primary care component to this would just increase costs more? Or am I going down a rabbit hole that makes no sense? I'm just curious if that's a part of the reason for it.
Yeah, it's an interesting question. I mean, I think probably multifactorial why we're seeing utilization trends higher in the specialty space. I think probably there are a recognition that there's really good data to show that a primary care physician may be able to support your clinical condition up to a certain length of the clinical pathway, say for a heart condition, But really, when you introduce a specialist, that's when you can drive additional value when a clinical condition becomes more complex. So I think maybe a recognition of that the coordination is important in driving care. So, and that coupled with maybe some reduction in barriers. I would say that another thing that we're seeing, frankly, is just innovation in the specialty space, whether you're talking about oncology or cardiology or musculoskeletal disease. Oncology, there are conditions or oncologic diagnosis that, even 5-10 years ago would have been, a death sentence. And now with kind of the rapid innovation we're seeing in the drug space, in the surgical space, some of these oncology diagnoses are becoming treated more like chronic conditions. And what does that mean? They just are going to touch their specialists more. And that's an oncology example, but you can say the same thing in patients with heart failure in cardiology or patients with musculoskeletal diseases. So I think there are rapid advancements in the specialty space, which means that these patients are, living longer with these particular diagnoses and therefore seeing their specialists longer and seeing them at a higher intensity.
Hence, if that's the case, getting the attention of health plans, getting the attention of employers, getting the attention of, the government, right? I mean, if the proportion is going up and we're assuming there's a greater spend. So given that, just kind of making that assumption, but given that, what are we looking at and it's a very broad question. I've got a bunch of them in this area, but just what are we looking at when we're thinking about value-based care models in the specialty space, such as in oncology? You mentioned cardiovascular. I could think of obesity. You mentioned musculoskeletal. How does it work differently? And maybe a little bit on, the old OCM and EOM and things like that might be helpful for people.
Yeah, perfect. Happy to kind of go through some of I think the importance of specialty value-based care, I think in general. I think a lot of themes overlap, but there are definitely differences. And I think one of the ways to start to first think about it is, again, we've defined value-based care a little bit, but maybe it's worth just doing that for the sake of, level setting the conversation.
Sure.
We head into it. But, when we talk about value-based care, it's really, again, designing care models that focus on quality, provider performance, and the patient experience, and then also being responsible for the cost of care for our population. And so we've already talked about what that means for an accountable care organization, right? They are a risk-bearing entity, meaning they are responsible for or at risk for financial and quality outcomes for their patients. And what's important is that risk that they bear doesn't stop at primary care-focused clinical outcomes and costs. So if the patient has a diagnosis of cancer or newly diagnosed with heart failure, they're also responsible for the costs and quality for those patients also. And then, if we take that from a patient perspective, they need the expertise of the specialist physicians for conditions in that space, like oncology or cardiology, to help support their primary care physician. And so what we see is that value-based care, again, as we define it, is to really improve our ability to manage the whole person. So costs and quality for both primary care and specialty care integration. And I think what's obvious in hearing that is that there's a couple of things that are very different when you think about primary care metrics and specialty metrics. Let's take oncology as an example. So for oncology, there is really a focus on the patient experience in terms of, what are some big buckets here? So some of the big buckets are, how do we improve outcomes by delivering personalized treatment plans, as an example? That's a big bucket in oncology that's very different than, if you dive into it, than a primary care physician. We use things like genetic and molecular profiling to tailor treatments to individual patients. The focus in a large part in oncology value-based care is around drugs. That's 40% of where the spend is focused for oncology care. So all of our value-based care elements, and a lot of our value-based care elements, sorry, not all, really focus on how to better deliver the right treatment at the right time at the right place. So thinking about things like genetic and molecular profiling. Another bucket for oncology, care in general is care coordination, right? So one of the things we frequently see as themes or issues is that there just isn't great collaboration or communication between a primary care doctor and the oncologist. And so things like cancer care navigators, folks that are able to bridge that gap between primary care physicians, oncologists, and really all the innumerable physicians that might touch a patient to help manage side effects, manage comorbidities. So it's a patient that has a diagnosis of, say, breast cancer, but also has diabetes. How do we ensure good coordination between those patients? So again, when you think about oncology, it's just, you dive into the clinical approach, they're just different. And then finally, cost management when we think about driving value in terms of savings for the health plan, the providers, the patient with their out-of-pocket costs. It's making sure that we have the right high-value pathways and guidelines for drugs and treatment, and we're trying to avoid unnecessary interventions. And so that's just an example, but those are some of the ways that value-based care, differs for specialty versus primary care. They're really looking at different things, even though they're trying to manage the whole patient.
So here's where I get confused, and I think where maybe a lot of other folks might have kind of look at this in the same way. Let's just use UPMC as an example. So Evolent has its roots in UPMC, and let's say that through UPMC, one of their health plans, someone and let's just use the same example, and we'll say in breast cancer. So on the one hand, in the old way of thinking, it's going to sound awful, but purely from a revenue standpoint or from an expense standpoint, if you have somebody dying after a year or two, you're better off because you're not, if you're from UPMC's perspective, because you're not paying out additional claims. It's terrible to think of it that way. But as people start living longer, and as the treatments get better, and as the drugs get better, well, maybe they're working, and maybe it's not, as you said, a death sentence. It's a manageable condition. And so the expenses are going up, and I'm imagining part of what the value-based model is trying to do is eliminate unwarranted expenses through the use of things like navigators, through technology, through pathways, through other things to eliminate what we would talk a lot about at Dartmouth was unwarranted variation, right? And so you have this on the one hand, costs increasing because you're spending more, but people are living longer. And so I'm just wondering how you deal with that in a value-based setting. And there's sort of like there's an additional component that I want you to address, which is, let's say that there's a value-based arrangement around a drug or a combination of drugs. And the expectation is that this person, based on this regimen, will have a certain set of outcomes, including an additional 2 years of life. But on a patient-by-patient basis, some don't quite make it that far. And so then the drug, you could say, is one of the things that didn't perform. And there might be, and I know in the cancer space, this is a little different than talking about HbA1c, with diabetics. But it's a really long question. I'm still trying to get my arms around it, which is, how do you deal with the value component when there's going to be additional spend, but at the same time you're getting additional value? How do you deal with all of the, and some cases where the drug may be helping, the drug may not be helping as much. And so you could say, well, maybe there's some rebates involved in some kind of value. Help me understand these dynamics in the specialty space. And maybe let's just continue talking in oncology.
Yeah, I think it's great to verbalize all these, because these are these like mental gymnastics is what everyone has to go through in order to be able to think through this space. And then there's times where, even I love the mental gymnastics, and even I have to beat my head against the wall to figure it out, and I would say, a couple of things here. I think, I think you call a spade to start and say that, in our current system of, and we're using the oncology example, there are unfortunately perverse incentives to deliver drugs. The way that health systems providers might be reimbursed is by the delivery of a particular agent. And so,
and just let me interrupt briefly. If there's a specialty pharmacy involved and it's owned by the payer or it's owned by the health system, there's that incentive to make money on that. Okay, so
absolutely. I think I would say a lot of complex, both regulatory and stakeholder environment that at the end of the day all contribute to, again, these perverse incentives in oncology. And I think a couple of ways that we, think about changing how we approach, let's say, value is really thinking about a couple of things. So you brought up this idea about, inappropriate drug chemotherapy, immunotherapy use, and maybe it's inappropriate because they're using it at the end of life, when there might be marginal benefit. Or a more common example would be it doesn't really align with the goals of care of the patient themselves. When we think about our value-based models, that's where we probably focus first is how did we incorporate advanced care planning? How do we incorporate shared decision making? How do we incorporate, what would you want to do in an end of life conversation? How would you want to approach your treatment plan? And truthfully, those are things that, until recently, and I think models like EOM and OCM prior and even, risk-based conveners like ourselves are doing is really introducing those concepts as central to how providers might get, potentially reimbursed, or health systems might be reimbursed, but most importantly, including the patient in those conversations so that they can drive some of the quality. And so I think, I think that's an important first step, is realizing, again, the incentives don't always align because to date, providers don't have the time, nor are the incentives aligned for them to have those kind of conversations, but in the right model, they would be. And I think that would drive a lot of value, obviously from a patient perspective, but also you can realize the financial implications when you have a great advanced care plan in place, or you have an advanced directive in place that really isn't just, you've had this conversation with the patient, the patient's had this conversation with the family's had this conversation with the provider. Really, that whole loop, that changes, that really changes the quality of care that's delivered and also the costs associated with it. So that would be maybe my first point. My second point would be thinking about the different pathways and just high value pathways in general for oncology care delivery. And I think it applies to cardiology and musculoskeletal disease. But when we think about oncology drugs, sometimes I think folks, obviously, that are looking at the budget tend to fixate on the fact that this is the most expensive drug, and therefore we want to not use it, or we want to try to avoid it. And really, our approach, and I think the approach of folks implementing these value-based models, is let's think about quality first. Let's think about quality second, and then let's think about quality third. Let's then think about costs. And I think an example for that are there are certain regimens that, yes, they're absolutely more costly, but utilizing that particular regimen might mean you have a higher recurrence-free survival. You might have lower progression of disease. You're less likely to progress and need expensive second or third line therapies. So by driving quality of care in that angle, you're actually, obviously foremost driving quality for the patient in terms of the care they're getting, but also you're avoiding some of the downstream costs associated with managing those diseases that progress because they didn't get the right treatment up front. I gave you an example of, genetic testing, but in genetic testing, if you're able to ensure that the patient is getting the right tailored treatment based on their genetic profile, you're actually avoiding costly treatments later on. And while the genetic test itself might be potentially expensive, downstream, if you think about the whole pathway and not just that 90-day period of active treatment where they're receiving the drug, that's where you're really deriving the both quality and savings that, like I said, the mental gymnastics are really hard to kind of navigate around if you're not really thinking about the whole journey for the patient.
I wonder if the conversation over time, if it's changed. And what I mean by that is going back 20, 30 years, you'd hear the statistics about how the U.S. healthcare system wasn't performing compared to other countries. Those things have been around forever. And then you'd see a lot of discussion around costs. And I would imagine a lot of the employer conversations with plans or benefit brokers at the time would have been very much about reining in costs from an annual basis. And maybe the person on the other side was saying, well, we have these wellness programs and we have these other things that are different from our competitors. But it was really so much focus on the numbers. And now I'm wondering if there's a more intelligent conversation that's happening that says, all right, well, in your population, costs are going up by X, Y, Z, but look at what we're doing in cancer care for your employees who have been battling cancer. Look at what we've been doing in the CV space for those that are having heart problems, heart failure, one of a million different conditions, and that the employers and other people who are paying for these plans, that it's a different kind of conversation. Are you seeing that, or am I right about that?
Yeah, I think I totally agree. I think the patient or member experience for a health plan, that is paramount to them in terms of what we're able to deliver. And the patient voice is extremely important. And we're seeing that, for a number of reasons, right? Health plans right now, or if we sympathize and walk in their shoes, they are facing, some of the biggest hurdles in terms of financial viability, currently. And we're also seeing higher utilization patterns than ever before. We're seeing regulatory changes and how utilization management or prior authorization has to be delivered. We're seeing a focus on the patient and member. And for all those reasons, the patient and member experience is extremely important for them, not only from from all the things that we listed, but even from a financial perspective, to be able to keep this membership, to keep this, to keep members engaged in their particular health plan. And I would say one of the other things that we see is that when we talk about these risk-bearing PCP entities or accountable care organizations, they have the delegated risk from the health plan. So they have a loud voice, right, in how
Sure.
they want their patients to be managed and the benefits that they're seeing. And that has an impact as well on this conversation change, as you said. So I think for all those reasons, I think we're definitely seeing a change in conversation. Blunt instruments that were typically relied on, just pure cost measures, are not valuable, as valuable as they were. You really think about engaging the patient, engaging the provider, and thinking about how you're supporting the whole journey in order to be successful.
So when I think of Evolent, I've always just in my mind just thought of pathways. Like that's one of the main things that you're bringing to the table. But you've also said something a couple of times, which is risk-bearing convener. So if I understand things, and obviously we're not here to just talk about your company, but really what you're looking to do is not just implement the pathways, but also set up the incentive structures in such a way that people are behaving with those pathways appropriately. And then based on the outcomes, good, bad, somewhere in the middle, then you're also rewarded for that in some sort of graduated schedule. Is that right?
That's right. Yeah. I think, pathways are an important part of our ability to deliver, less variant care. And really, I would say the difference in many ways is there's pathways, and then there's pathways built by oncologists, pathways built by cardiologists, pathways built by experts in musculoskeletal disease. And I think there's a lot of value when you think about specialists building specialist pathways. So I think that's one area that I think is unique. And then absolutely, when you talk about oncology, we take risk on the drugs for oncology for, certain populations of our patients, right? That's very scary for a lot of folks to even think about, given how much tremendous, again, we talked about costs, variation, and or what I would say is increased innovation. So we very much take risk on the drugs because it gives us the latitude to do exactly what you said. Change the incentive structure so that we're focused on quality. Reward the providers for being able to deliver higher quality of care rather than, maybe focusing on the bottom line of some of these drugs. It also gives us the latitude to do innovative things like, build a member program. We have a strong member initiative that's focused on helping patients navigate advanced illness, end of life, navigate the active treatment world with our, oncology navigators and our licensed social workers who have expertise in motivational interviewing, so that we create those connections between primary care and specialists. So being able to take risk and be that kind of convener gives us the latitude to do these very creative things that engage the providers, engage the patient, engage the health plan, and really engage that iron triangle to drive better quality and improve costs, for a very complex condition.
Do you ever get involved directly with manufacturers in some of these kinds of discussion? Do you bring them to the table and, with some of these higher cost meds or is it always one step removed?
We typically don't. We have a pharmacy team that's, stays abreast of all the data and all of those things, but we typically aren't involved in, I would say, in the manufacturer angle. We do think about things like site of care and where certain medications could be delivered to, be a better experience for the patient as well as improve costs. But we largely rely on some of our kind of the regulatory colleagues, the work that, CMS is doing with the Inflation Reduction Act, et cetera, and keep a close pulse on those things rather than, work on that on our own.
I'm just wondering if it ever comes into play on the commercial side, not so much on the Medicare or Medicaid side, but if it ever comes into play. But it sounds like you're more like one step removed.
Yeah, not a lever that we typically pull.
Well, I'm looking at the time. I've got a couple more questions, but I've got the big one. I want to hit this one right now, which is where you see. We started off with kind of the state, and you gave us some numbers on usage of value-based care models. But what do you see happening over the next 2 to 3 years? What are the most, whether it's regulations, legislation, other new models that may be coming from CMS, like what do you see are the trends that we need to be looking for? When I say we, I guess I'm thinking of, health plan executives, health system executives, manufacturers, the people who are going to need to be planning for these things. What do you see on the immediate horizon?
Yeah, I mean, I think we touched a little bit on it, but in terms of, I think strong trends that we're seeing already is, again, in the past, there's been a strong reliance on risk coding in order to drive financial value. We're seeing regulatory changes already that came down, like the V28 modifier, that basically took a lot of that off the table. And what that means is both risk-bearing entities like ACOs and health plans have to find a different way to drive quality and drive financial value for their patients. And I think that specialty care will only continue to grow. I mean, there are some statistics, at least in the oncology space, where we're seeing costs going from, I think it was like 180 billion in 2015 to nearly 246 billion by 2020, which we've already crossed. So it'll be even higher in the coming years. I think specialty care and value-based care models that really think about incorporation of specialty care will become paramount, because a lot of the costs will center around how we manage those costs. And while, I think ACOs and health plans have, had some success to date, we still haven't figured out a great methodology for it. I think what we're seeing is a movement across. So we'll take CMS, for example. There's a launch. They've launched a mandatory bundle, the Teams bundle. We've seen, obviously, the launch of EOM. We're going to continue to see some of the work in that space with the Making Care primary model, where in the more mature track, it's like a 10.5-year model. In a more mature track, there's going to be a focus on connecting primary care and specialists. So I think that there's a financial imperative, there's a clinical quality imperative, there's a patient experience imperative to really figure out how does specialty care really fit into these models. What are the right models to implement and scale? And we won't pretend to have all the answers, even here at Evolent, but I think we are making a lot of headway into thinking about what the foundations look like in order to better manage these very complex conditions. But I think that will be top of mind for every one of those stakeholders you listed.
So, and I'm thinking just a follow-up is just specific to the manufacturer component of this. And thinking again in oncology where, 40% of the spend, should manufacturers be building in, and I know a lot of them are doing this already, but how important is it that they're building in sort of value analysis into their clinical trials?
I think we're starting to see it already, with expensive drugs like CAR T, et cetera, that those manufacturers are coming to work groups and working closely with some other risk-bearing conveners, to figure out what is the value analysis. Are we able to ever get to the point where we're paying for a drug based on value of the drug? And I think that there is a movement towards that. I think, again, it's operationally complex. There's a lot of players and regulatory changes that are currently happening that will probably influence how quickly these changes happen. But it is definitely on the top of mind for many pharmaceutical companies or manufacturing companies to really think about what their role is in a value-based model. And I think we, again, the story is still being told on what that will look like, but I think we will see that in the next 5 to 10 years. You think about value-based insurance design and some of the other levers that we have. How do those impact, what a manufacturer, potentially charges for a particular drug, or how they support patients when they have an expensive drug? I think those are all under close scrutiny, and those only get more intense as time goes on.
Last question, and I have to ask it since these two letters seem to pervade everything, and not just in healthcare these days, but the role of AI in value-based models. Are you seeing any, meaningful introduction of AI in the space of being able to extract greater value, maybe by identifying, certain endpoints that weren't looked at before? But have you seen AI start to play a role in this space?
I think AI is so powerful that I think it would be foolish of me to say that it doesn't have a role, and I think it does. I think in order to understand, the true risk of a patient, all of the clinical components, and being able to synthesize that in a way that a clinician or a risk-based convener or a health plan can use that to better improve the patient experience. I think being able to ingest all that data quickly and be able to put it in a really readable format is, I think, it's happening in small pockets across the industry. We had our own AI company acquisition, and we're figuring out how we want to use it as well and how we're deploying it. So it definitely is going to play a big role. And I was recently listening to another podcast, and I really loved the phrasing. We say AI, artificial intelligence, but I think in some ways, especially in our industry, given the expertise of our clinicians, I think they use the word IA, which is intellectual augmentation, which I think is really where there's a strong benefit. And I think making the provider experience better, making the patient's fragmented experience better, making sure we pull in all those components that, are really just sometimes hard when you're in a fact-based system, everyone's on a different EMR, and you're seeing 10 different physicians. How do we make that process more cohesive? I think AI is going to have strong inroads into doing that. And I think specialty care and primary care integration, we see some of the same problems. So it'll be exciting to see how AI, really makes those connections stronger.
Terrific. Well, Dr. Golla, thank you so much for your time. I really appreciate the conversation. I feel like in a little more than 45 minutes, we've scratched the surface. So I might have to ask you back in the future and see how things are going, and maybe fill in some of the blanks, because there's so much to talk about. I find this topic, even though it's one of the most talked about topics in healthcare, I still find it one of the most fascinating because the solutions are not easy. They're not left to sound bites. Like you said, bang your head up against the wall with some intellectual gymnastics.
Yeah, I totally agree with you. And I think it's important to talk about it. I think it's important to, talk about where it's difficult, where we're making headway. I'm the eternal optimist. And so I think we are making improvements and headed in a better direction, but it's still a lot of work ahead of us. But I think, talks like this and getting this out is super important.
Excellent. Well, thanks again. And that'll do it for another episode of Healthcare Rounds. Our guest today has been Dr. Kmal Golla, Senior Medical Director for Value Transformation at Evolent. As always, I'm your host, John Marchica, CEO of Darwin Research Group. And please do us a favor, leave a rating on Apple, Spotify, or wherever you listen to the show. And if you haven't already, have a look. We're up on YouTube. See you next time on Healthcare Rounds. Take care.